from the Department of Pediatrics. Okay, so in this particular seminar, we are going to discuss about childhood malignancies, and the most important of them is leukemia, because it's also the commonest childhood malignancy. Within leukemia, we have ALL and AML. We'll be discussing ALL in more details. Then we have lymphomas, which are the third commonest malignancies in childhood. And thirdly, in this lecture, we have clubbed together Wilms tumor, although it is not the commonest childhood amongst the commonest childhood malignancies, but if you consider kidney tumors, that is renal tumors in children, amongst them Wilms tumor is the commonest. Okay, so this is what we are going to cover today: leukemia, lymphoma, and Wilms tumor. So let us start with the incidence. So this shows the incidence of various malignancies in children between 0 to 14 years of age, and then you can see the largest part of the pie chart is occupied by leukemia. So almost 30% of childhood cancers are leukemias, which are blood cancers. Then the second commonest are CNS tumors, which are around 25%. The third commonest are lymphomas, which are 10%. And we are going to discuss leukemias and lymphomas in slight detail. Apart from that, you look at this light blue pie, which is renal tumors, which is around 5% of childhood malignancies. And amongst these renal tumors, Wilms tumor comprises almost 90%. Okay, so that is the one renal tumor that we are going to discuss. So what are the types of leukemias? There are 4 different types of leukemias, the major types. One is the acute lymphoblastic leukemia, that is ALL. So 75 to 80% of all childhood leukemias are ALLs. Amongst these could be B cell ALL or T cell ALL. So the origin of these leukemias is acute lymphoblastic leukemia are the lymphocytes. So, and lymphocytes are of 2 types, B cells and T cells. So you have B cell ALL and you have T cell ALL. So B ALL comprises 80 to 85% of all ALLs, and T cell ALLs comprise 15 to 20% of all ALLs. Apart from that, you have acute myeloid leukemias, which are the remainder 15 to 20% of childhood leukemias, and the less common forms, that is chronic myeloid leukemia and JMML, that is juvenile myelomonocytic leukemias. So by and large, the commonest ones is the acute lymphoblastic leukemia. So what exactly is leukemia? This is the definition which you should know. Acute lymphoblastic leukemias represent a clonal expansion and arrest at a specific stage of normal lymphoid hematopoiesis. So what happens is, I'll just explain this particular, and this definition is not just of acute lymphoblastic leukemia, but of acute leukemia. So even acute leukemias are has the same definition. Okay. So what it means is that if this particular slide is showing you the normal hematopoiesis which occurs in the bone marrow predominantly. Okay, so bone marrow is the area within the bones, that is where origin of all blood cells occurs. Okay, so what happens within the bone marrow is there are certain hematopoietic stem cells which divide and mature. So it divides into a lymphoid progenitor and a myeloid progenitor. The lymphoid progenitor further replicates and then matures. So there are 2 factors to it. One is replication and the other is maturation, that is differentiation. Okay, so these lymphoid progenitors divide and they mature to form the lymphocytes, and lymphocytes can be B lymphocytes or T lymphocytes. And there is a myeloid progenitor which multiplies and differentiates to give rise to the RBCs, the platelets, and the remainder types of lymphocytes, that is neutrophils, eosinophils, basophils, and monocytes. Now, what happens in leukemia is there is a clonal expansion of either the lymphoid progenitor or the myeloid progenitor. So, if there is clonal expansion of the lymphoid progenitor with an arrest of maturation, so they keep on multiplying, but they do not differentiate to form the cells they are intended to form. So that particular cell clonal expansion without maturation leads to acute lymphoblastic leukemia. Now the same process, if it occurs with the myeloid progenitor, it gives rise to acute myeloblastic leukemia. Okay, understood? So clonal expansion and arrest of differentiation that leads to leukemias. Whether at what stage and what cell undergoes that clonal expansion and lack of maturation, it decides whether it is an ALL or it's an AML. Now, what is the epidemiology? The peak incidence is between children, peak incidence of ALL. So this epidemiology is for ALL. The peak incidence occurs in 2 to 5 years of age. Okay, AML does not have a age peak. Okay, so the ALL is slightly commoner in boys and it occurs more in whites than in blacks. Then what are the risk factors for ALL? So henceforth we are describing ALL in slight more details as compared to AML. Okay. So what are the risk factors for ALL? One is ionizing radiation. So ionizing radiation in today's date and age, where does it occur? Usually pregnant females, when they had x-rays in the past, that leads to radiation exposure of the fetus in utero. That doesn't happen in today's age. What happens in today's time is that children who have osteosarcoma or some other malignancy, or for some other indication, if they have received radiotherapy, that leads to radiation exposure, or if someone has had multiples of CT scans, that can lead to increased radiation exposure and increase the risk of leukemia. Then second is exposure to certain chemicals like benzenes and nitrosoureas, and you also have the vehicular pollutants. Then there are certain genetic syndromes. So there is an entire list, but if you have to remember one genetic syndrome which predisposes to leukemia, it is Down's syndrome. So amongst the genetic syndromes, you can have Down syndrome, you can have Lee-Fromeny syndromes, neurofibromatosis, and ataxia telangiectasias. Okay, so in these, if you have to remember Down syndrome, what you need to know is, and Down's children, they have almost 20 times increased risk of developing leukemia. So look at this picture. If you look at this picture, it is a typical photograph of a child who has a flattened face. He has mongoloid slant of the eyes. He has a flat nasal bridge. Pinna is not visible, but the look of the child is very much typical of a Down's phenotype. And in Down syndrome, there is a 24 increased risk of leukemias. Also, you should know that when a Down's child has leukemia, as compared to a normal child, his prognosis, despite treatment, would be poorer. Now, what is the classification of ALL? Previously, so I'll tell you two schools of classification. One is the WHO classification of ALL, which is the recent one and which is the more relevant one for us. Okay, and the other is the FAB classification, that is the French, American, British classification of ALL, which is the older classification that we used. So this WHO classification is primarily based on genotyping and cytogenetics of the malignant clone. So whatever malignant cells in the body are there, whether they're in the bone marrow or the blood, they are taken out, and on those malignant cells you look at the cytogenetics. For example, you look for certain defined abnormal translocations or abnormal mutations which has been described by WHO. Okay, you try to identify those mutations and classify ALL according to the presence or absence of these mutations. So it is based on a genetic abnormality in the malignant clone, whereas the FAB classification was based on the pathological appearance of the malignant clone. So the blood sample or the bone marrow sample was looked at the slide by a pathologist, and depending on what appearance that malignant clone had, they had given the FAB classification as L1, L2 and L3. Now this WHO classification that has been given is more relevant because it helps us to classify ALL based on these genetic abnormalities, and it has more relevance in terms of treatment and prognosis. So based on the presence or absence of certain genetic characteristics, the child with ALL can be classified into having low risk of death and disease relapse or high risk of death and disease relapse, and the chemotherapy which is given for their treatment is modified according to the risk stratification. So WHO classification is far more relevant and you should know this. A very broad classification, if I tell you, BALL can be divided into two types. BALL with recurrent genetic abnormalities. So WHO has given 7 such recurrent genetic abnormalities. Amongst these, if there is one that I want you to remember, amongst the 7 of these recurrent genetic abnormalities, the one that I want you to remember is translocation 9, 22, that is the Philadelphia chromosome, which if present classifies the ALL child into high risk. So they should receive a more intense chemotherapy. Okay. And in those children in whom none of the defined recurrent genetic abnormalities are identified, they are labeled as BAL, not otherwise specified. And then you have TALL, for which WHO has not yet been able to identify any recurrent genetic abnormalities. Okay. Now this is the FAB classification of ALL which was used previously. You can go back and read this in these books. This is more of a concern if you have certain older schools of thoughts taking your vivas. Okay, so that will be relevant there. You can go back and read this in the book. Then what can be the clinical presentation of ALL? So there can be certain general symptoms. Okay, so general symptoms include that should be apart from the commoner ones that you think of. Okay. Then the second clinical presentation is due to bone marrow invasion. So what will happen is, because bone marrow is the site where these leukemic cells originate, they keep on expanding and they do not mature. So basically they are useless. They are not going to be functional cells. But in the process, they are also replacing all the normal bone marrow cells. And what all normal cells are formed? There are WBCs. So normal WBCs are going to reduce. And because of that reduced WBC count, there is increased predisposition to all sorts of infections. One of them is oral candidiasis. So oral candidiasis, this particular picture, if you look at the top, there is a whitish coating, and if you're trying to peel it off, it will not peel easily and it is going to bleed. This is oral candidiasis, and this does not occur in normal children. It only happens in immunocompromised children. So the second is decreased HB, because RBCs are not going to be formed properly in the bone marrow. So there will be progressive pallor, and it is seen in almost 40% of these leukemia children. Then there are going to be decreased platelets. Because of decreased platelets, there can be petechiae, epistaxis, hematuria, and melena. So there could be bleeding from any of the sides. Now look at this picture on the left. This is the shin of the tibia that can be seen, and over here circled in black are the petechial spots. So this is because of low platelet count that these petechiae have formed. Then the third set of presentation is due to lymphoid system infiltration. So lymphoid system consists of lymph nodes and the spleen, and apart from that, liver involvement can also be there. So lymphadenopathy, splenomegaly, and hepatomegaly, because once the leukemic clone has infiltrated the bone marrow, it will spill into the blood, and it is going to form niche inside these lymphoreticular system. So lymphadenopathy, splenomegaly, and hepatomegaly can occur. So if you look at this picture, this child has so many cervical lymph nodes which are enlarged and conglomerated, which is a significantly enlarged cervical lymph node group. And the last set of manifestations are due to extramedullary involvement. So once they've infiltrated, once the leukemic clone has infiltrated the bone marrow, after that it spills into the blood, goes into the lymph nodes, spleen, and the liver, and after that it can infiltrate any organ of the body. Okay, so extramedullary, apart from the bone marrow and apart from the lymphoid system, extramedullary involvement can be there, and it can infiltrate any part of the body. So if the CNS is involved, it may lead to cranial nerve palsies, or it can lead to seizures or racicity. If it involves the gut, it can lead to necrotizing enterocolitis. So the colon wall is necrosed because of the infiltration with leukemic cells. The colon wall gets necrosed and thinned out. It can lead to typhlitis, which is inflammation of the cecum. Then it can lead to bone and joint involvement. This particular one is very important because there are certain children with leukemia who may present with just fever and with joint pain and bony pains. So in such a situation, what will happen is that if a mother comes to you and says that I have this 7-year-old male child, and he has been having fever for the past 1 month on and off, and now for the past 2-3 days past 1 week or so, he's having bilateral knee joint involvement, which is showing swelling also, and he's finding it difficulty in walking. So the first differential that actually comes to your mind, and he has a normal cardiovascular system examination. So once you find out that okay, this is not fitting into RHD, and your next thought process would be कि septic तो नहीं है, sepsis नहीं है, तो you start thinking of juvenile idiopathic arthritis. Now there have been cases where such kids have been labeled as juvenile idiopathic arthritis and started on therapy, and later when they did not respond, it was found out that they actually have leukemia. So it is very important that you keep this differential in mind when you have such children with fever and only joint pains and swellings. This should also be in your mind as a differential. Okay. Then you have genital urinary involvement, where due to the involvement of the testes, there is testicular mass. So in children with leukemia, it is essential that you examine the testes for any testicular mass in the male children, because if the testicular involvement is present, it will not only change their risk stratification, they will go into a higher risk category, but it may also entail giving radiotherapy to these children at the local site depending on their response to initial therapy. Okay, so it is important to have this tested. Okay, so then we said that there are 4 sorts of clinical presentations in these children. 1, general symptoms, that is fever, lassitude, anorexia, weight loss. 2nd, due to bone marrow infiltration, the normal cell lines are damaged. So low HB pallor, low WBC infections, low platelets, bleeding. The 3rd is because of leukemic infiltration into the lymphoid system, so lymphadenopathy, hepatomegaly and splenomegaly. And the 4th is because of extramedullary involvement of different sites, of which, do not forget, bony pains and arthritis. Okay, and of course the testes. Now the next is, what diagnostic investigations are you going to do? So the first diagnostic investigation, so when you have any child with leukemia, blood examination, bone marrow aspirate and biopsy, certain biochemical investigations, and radiological investigations. Okay, so these 4 categories of investigations are always going to be there at the baseline. Okay, so blood investigations mean you have CBC. So in a leukemic child, what should a CBC show? What can you? I've already projected in the slide, so no point of asking. But they can be low HB and low platelet with leukocytes. So HB will be low, platelet will be low, but TLC would be higher. So 20,000, 30,000, 40,000, 50,000. So you can also have a confusion with whether it is a leukemoid reaction, but a peripheral smear is going to give you the answer and the differential count. So what will happen in this differential count? There will be lymphocytosis. So the machine will say only 5% neutrophils, only 10% neutrophils, and the remainder entire batch is 90% lymphocytes. Okay, so that will happen. Less commonly, what can happen is leukocytosis is not present. So the TLC is actually lower than the usual. Normal TLC is between 4,000 to 11,000. In such children, those with aleukemic or subleukemic leukemia, they have less number of malignant clones circulating in the blood. So in the blood, actually the TLC is lower, less than 4,000, and you are unable to say that this it confuses you whether this is actually leukemia or not. In that situation, and otherwise also, you go ahead with a peripheral smear. So what will you see in a peripheral smear? Again, there will be a confirmation of low RBC count and low HB. There will be a confirmation of thrombocytopenia, and you will see either leukocytosis or in some cases leukopenia, and typically a good pathologist will be able to characterize blasts. So the blasts will be seen on the peripheral smear. Now, how do the blasts look like in a peripheral smear? So can someone tell me what these blasts are? Someone has asked me what is lassitude? Lassitude is nothing but malaise and fatigue. So please, in the chat box, can someone just explain what you see in this peripheral smear? Anyone? Anyone? White cells? No. Let's just focus on what we have at the center. Okay, so if you look at this particular picture, let's first start with what is normal. These are the RBCs. Okay, so these are the RBCs. Now normally what are you supposed to see? You're supposed to see neutrophils and lymphocytes, right? And lymphocyte size is usually almost similar to or slightly larger than the RBC. Now look at these cells. They are larger, significantly larger in size as compared to the RBC. They do not have any neutrophil-like characteristic where they will have a segmented nucleus, right? So that is not present. Now, what is the nucleus like? That is typically such a large nucleus which is occupying the whole of the cell, very little cytoplasm which is agranular, and the chromatin appears very granular. Okay. So what is this? These are the cells of ALL. So the chromatin is clumped together. So this is typical of ALL. Okay, now look at this slide. What does it show? Again, it shows these RBCs. Now there is another cell. This does not fit into either this is not an RBC, this is not a platelet, this is not a lymphocyte because the size is going to be smaller for a lymphocyte. This does not look like a monocyte or any of the other normal cells, neutrophils, eosinophils, that basophils that you see. What you look over here is a large cell with a nucleus which is almost 2/3 and a granular cytoplasm. And what do you see in this cytoplasm? Can you see these needle-like structures in the cytoplasm? Yes. So these are the OR rods. Okay. And OR rods are present. They are characteristic of a myeloblast. So these are OR rods and characteristic of myeloblast. And this is a case of AML. So this is an ALL peripheral smear and this is an AML peripheral smear. So you do a CBC in investigation and you do a peripheral smear, and if blasts are present in the peripheral smear, a pathologist will give you a good idea of what sort of blast. But often what happens is that these children come with reports from outside, and the pathologist who's sitting in the periphery may not be very well versed with seeing these blasts. So they may simply report atypical cells are seen. And when you have such a report in your hand, always make it a point that you get either the slides retrieved or a fresh sample is sent to the pathology department to find out characteristic of this atypical cells. Okay. Now, the next set of investigations in these children is bone marrow aspirate and biopsy. So what all do you run on a bone marrow aspirate and biopsy? One, you do a microscopic examination. Second, once you've done and what will you get on a microscopic examination? A normal bone marrow has less than 5% blast. So if you do a bone marrow on me or any other normal person, then number of blasts in the bone marrow would be less than 5% of all the cells that are present in that bone. For a patient to be labeled as having leukemia, you need to have more than 20% blasts in the bone marrow. Means more than 20% of the cells of the bone marrow are blasts. So this is necessary for labeling the child as having acute leukemia. The second thing that will happen on a microscopic examination of a bone marrow aspirate slide is that the pathologist will again look at the morphology, just as they looked in the peripheral smear. They looked at the morphology in the bone marrow and tell whether this looks more like an ALL blast or it looks more like an AML blast. So microscopic examination gives you a good idea, but it's still not confirmatory of what type of ALL or what type of leukemia it is. It will tell you that it is leukemia because 20% is other blast is going to be leukemia. But you cannot confidently say that it's ALL or AML just on the basis of microscopic examination. So what does the pathologist then do? He puts a cytochemical stain on this bone marrow slide. So there are 4 cytochemical stains. I'll give you the importance later. Thirdly, what they do is they do immunophenotyping by flow cytometry. So whenever there is a child with leukemia, you have that child, you do a bone marrow aspirate process with a resident. He makes certain slides from that aspirate, which is sent for microscopic examination and cytochemical stain, and he also collects that aspirate in an EDTA vial. Now this is a liquid sample. Bone marrow aspirate is a liquid sample. This liquid sample is subjected to flow cytometry. So on this basis of the flow cytometry, it is characterized which I'll later explain what sort of cells are there, whether they're ALL or AML, and this sort of confirms that whether the leukemia is ALL or AML. And lastly, you run a karyotyping and cytogenetics on this bone marrow aspirate malignant clone to find out in what WHO classification they fall, whether high risk or intermediate risk or standard risk ALL. Okay. So now first coming to the bone marrow examination, morphology. So look at this slide. These are blast cells. So normally these blast cells are less than 20%. Over here there are more than 20% blast cells in the bone marrow, and this is characteristic for diagnosis. Likewise, in this situation on the right side also, the myeloblasts are more than 20% of the bone marrow, so it is diagnostic of AML. And if you look at the morphology of these two blasts, they are different. Okay, so based on the size and morphology, the pathologist is able to say whether it is a myeloblast or it is a lymphoblast. Now, cytochemical staining that I was telling you, there are 4 stains that we use. ALL is positive for PAS. AML is positive for MPA, Sudan black B, and non-specific esterase. You have to remember one thing in this. If a blast is MPO positive, it is definitely going to be AML. Okay, but if a blast is MPO negative, then it may be ALL or AML. Okay, so it is important. OR rods, if present, it is definitely AML. But OR rods, if absent, it can be ALL or AML. Likewise for MPO. Just a minute, give me a minute. Sorry for the interruption. Yeah. So then you have immunophenotyping. So what is immunophenotyping? Like I said, the bone marrow sample which is collected in the EDTA vial. Now within those, what you have to identify is what type of leukemia it is, whether it is ALL or AML. So before that, I'll just tell you the concept of immunophenotyping. All blood cells in our body, whether it is B cell or T cell, whether it is lymphocyte, neutrophil, eosinophil, or monocyte, they have specific antigens on their surfaces, and these are known as CD markers. Okay, so these are clusters of differentiation. These are specific. So a certain combination of CD markers are present on the surface of each blood cell. Okay, it is like a thumbprint. So if a certain collection of antigen markers, CD markers, are present in a particular cell, which is detected by immunophenotyping, in that situation, you're able to tell, okay, this cell is B cell because it has this combination of surface markers present, or this cell is T cell because it has this combination of surface marker present, or this is a blast, this is a cancerous cell because it has this combination of surface markers present. So this is what, it's like a thumbprint. So immunophenotyping is the process by which you detect these antigens by using certain antibodies. Okay, so identification of these surface markers is known as immunophenotyping. Okay, so immunophenotyping on a bone marrow aspirate, when the cancerous cells are immunophenotyped, it helps in 2 things. One, it confirms the presence of blasts because those specific combination of surface antigens are going to present. Blasts are going to be different from normal cells. Okay, and it also distinguishes the myeloid blast from the lymphoid blast. So it is here that you are able to confirm whether it is ALL or AML based on the cell surface markers. But remember, these tests move in conjunction, whether it is microscopic examination, cytochemical staining, or immunophenotyping. None of them work in isolation. It is in conjunction that you diagnose these leukemias as ALL and AML, and within ALL as BALL and TLL. And why is this distinction so important? Why am I emphasizing? Why do you need to know the difference ki leukemia kis type ka hai? Because treatment will differ significantly between these subtypes. So to decide what treatment you have to give, you have to know exactly what type of leukemia you have. Okay. So the last thing that you do on a bone marrow aspirate sample is cytogenetics. So how do you do the cytogenetics? You again take the bone marrow aspirate in a heparin vial. So it's a liquid and it is subjected to karyotyping in fish. And with the help of these technologies, you are able to identify the 7 recurrent genetic abnormalities that WHO has identified. One of them is translocation 922. There are others like translocation 1221 and 411 and IMP 21. So it's okay if you don't know them, but you should always know that translocation 922 is present. And if a child is translocation 922 positive, he receives a more intense chemotherapy, and imatinib, which is a tyrosine kinase inhibitor, is used in the management of such children. Okay. Now the next, so we have within investigations, we have discussed blood investigations. Then we did bone marrow investigations. Now you have biochemical and other investigations. Within the biochemical investigations, you have KFT, LFT, and serum electrolytes. So henceforth, whenever I say biochemical investigations, listen to me carefully. Whenever I repeat biochemical investigations for lymphomas or for Wilms tumor, it will be the same set of investigations, biochemical and ancillary. Just listen carefully why we do these investigations, because the premise will remain the same in the next coming slides. Okay. So we do a KFT, LFT, and serum electrolytes because we want to see baseline involvement of liver and kidney, whether the baseline liver and kidney function is normal or not, or has the tumor cells led to dysfunction of these organs. Okay. And secondly, we want to know whether we can give certain chemotherapy drugs in these patients or not, because if the kidney or liver function at the baseline is deranged, then we are able to give some chemotherapy drugs and we are not able to give certain chemotherapy drugs because they themselves, the chemotherapy drugs themselves, can cause hepatotoxicity and kidney toxicity. Okay. So we will have to modify the drugs or their dosages accordingly. So that is why we need to have the baseline KFT, LFT, serum electrolytes. Why do you need to have the baseline uric acid levels and NTH levels? Basically, there is a syndrome known as tumor lysis syndrome. So in all leukemias and lymphomas and tumors in children, there is a risk of tumor lysis syndrome. That is, the cancer cells break down. When they break down, they release a lot of uric acid, potassium, and phosphate, and that phosphate which is released from the cells, it combines with the calcium. So ultimately what happens in the blood is there is hyperuricemia, there is hyperkalemia, there is hyperphosphatemia, and phosphate combines with calcium to cause hypocalcemia in the blood, and all of these parameters can lead to kidney dysfunction, that is renal failure, or other manifestations of hypocalcemia and hyperkalemia. Okay. So for monitoring that, the development of this tumor lysis syndrome, which happens usually in the first week of illness of starting chemotherapy, you need to monitor the uric acid levels and the kidney function test and serum electrolytes. Okay. And LDH levels usually correlate with the tumor load. Okay. In lymphomas, it also helps in risk stratification. Now the ancillary, so you got the premise of why we do these biochemical tests. Now ancillary tests like MAN2 and viral markers, MAN2 and viral markers for hepatitis B, hepatitis C, and HIV. These are done to find out if there is actually already a presence of Hep B, Hep C, or HIV in the child, because once you give chemotherapy, these diseases are going to flare up. They may be asymptomatic till now. TB may be asymptomatic, Hep B, Hep C, HIV till now maybe may have been asymptomatic, but once you start chemotherapy, it is going to unmask that infection. So if you find it positive, then you start concomitant Hep C therapy, Hep B therapy, or antiretroviral therapy in cases of HIV positive, or if you find TB to be positive, then you start ATT alongside with chemotherapy in such children. Okay. Secondly, you many a times give a couple of blood transfusions for these children. Although blood transfusions in today's times are very well managed, you do good screenings for HIV, Hep B, and Hep C, yet there is a possibility. And so for medical legal purposes also, you should have a baseline hepatitis B, C, and HIV. Okay. Now the last set of investigations, so blood, bone marrow, biochemical and ancillary, and radiological. Radiological investigations that you do in leukemias are a chest X-ray for all children. Okay, so chest X-ray may show the presence of mediastinal mass. So you look at this, normally this area is not so full. Okay, so over this area, this fullness that is present is because of mediastinal lymphadenopathy, or there is some mediastinal mass which is present, and this area is likely to be because of a lymph nodal mass. Okay, so if there is an anterior mediastinal mass, then there are two aspects to it. If a leukemic child has this, one, it leads to an upstaging of the risk if there is significant lymphadenopathy. Second, it may lead to compression of the trachea and esophagus, leading to complications related to the mass. So for your information, for proper treatment and management, you need to know whether there is a presence of a mass in the chest X-ray or not. Now we come to the slide where we know about the prognosis. So we've discussed about the definition, etiopathogenesis, clinical features, and the investigations that you do for diagnosing an ALL. Now there are certain prognostic factors in ALL. Before I count all these prognostic factors, what is the relevance of these prognostic factors? So prognosis for what? So you remember, when we treat ALL, different guidelines are available in the world. Okay, different people all over the world, different oncologists in the world have created different set of chemotherapy drugs and regimes and doses which have to be given to the children over a period of time for curing, for treating leukemia. Now, how do they decide what number of chemotherapy drugs or what dosages or how long should that chemotherapy or how intense that chemotherapy has to be given to a child? Depends on his risk stratification, because chemotherapy is a double-edged sword. If you give too much chemotherapy to a child, chemotherapy per se has side effects. Side effects like it can lead to immunosuppression and increased infections. It can have long-term side effects of decreased cognitive impairment. It can lead to cardiotoxicity. It can lead to renal failure. It can lead to hepatotoxicity. Yet at the same time, you have to give chemotherapy to kill all the cancer cells so that the child does not die because of the cancer per se, or he does not develop a relapse of the cancer later on. So you have to keep a balance. If you give extra chemotherapy to a child who does not need that much, you are going to increase the side effects. But if you give less intense chemotherapy to a child who needs it, then he may not get cured, or he may develop a relapse later on. How do we decide how much chemotherapy to give, how much intense chemotherapy we should give to a child? It is these prognostic factors. Okay. So different guidelines use different combinations of these prognostic factors and stratify the ALL children into standard risk, intermediate risk, and high risk. And depending on their risk, what is this risk? Risk of death due to disease and risk of relapse of the cancer later on. Okay. So if a child based on the combination of these factors, if a child falls into low risk, he is given a less intense chemotherapy, and if he falls into high risk, he is given a more intense chemotherapy. So this is one of the treatment principles of ALL, as well as why you should know these prognostic factors very well. So what are the favorable prognostic factors? WBC count less than 50,000, unfavorable is more than 50,000. 1 to 10 years is favorable prognosis. Any extremes of age is poor prognosis. Females have a slightly better prognosis if the cancer has spread to the CNS. So brain involvement, CNS involvement is poor prognosis. Amongst BLL and TLL, TLL has a poorer prognosis. Then you do these two rows. These are the cytogenetics. So based on karyotyping, you find the ploidy. What is ploidy? A normal ploidy is 46 chromosomes. You have 46 chromosomes in your normal cells. If there are more than 46 chromosomes, it is hyperdiploidy. If there are less than 46 chromosomes, it is hypodiploidy. Hypodiploidy is poor prognosis. Hyperdiploidy is good prognosis. Then there are certain mutations that you detect via cytogenetics. So amongst these, remember one, which is translocation 922, which is associated with poor prognosis. Lastly, but most importantly, amongst all these prognostic factors, the most important factor which decides whether the child will do well or not is response to chemotherapy. So how is this response assessed? It is done at day 8 of chemotherapy and at the end of around a month of chemotherapy. Okay, so they say that you do a peripheral smear on the day 8 and you look at the blast count. If it is less than 1000 blasts per cubic millimeter of blood, it is good prognosis. And then you do a bone marrow examination at the end of induction, and depending on that, if the MRD is less than 10 raised to the power -4, it means that the child has good prognosis. Okay. Now, treatment principles. One of the principles I've already discussed, which is the risk stratification, which I explained to you with the prognostic factors. The other thing is how you give a chemotherapy. There is a three-pronged therapy. You give induction. In induction, you give the first phase. So the first phase, 1 month is induction, where you give combination of 4 chemotherapy drugs, and it helps in killing the majority of the leukemic cells. So maximum number of cancer cells in the blood are killed during induction. Then there is post-induction therapy, which consists of 3 phases: consolidation, delayed intensification, and maintenance. So what do you do in consolidation? You give a different set of chemotherapy drugs, and it further reduces the cancer cells. In delayed intensification, you give a different combination of chemotherapy drugs. That means you give chemotherapy drugs from different classes, some alkylating agents, some metabolic anti-metabolites you will give. So different classes of drugs you will give, so that it minimizes cross-resistance, so that if a malignant cell is resistant to one class of chemotherapy drug, it is killed by the other class of chemotherapy drugs. So in delayed intensification, use a different set of chemotherapy drugs belonging to different mechanism of actions. Okay. And third is maintenance, which is done for almost 1.5 years, in which most of the chemotherapy is oral, which is given to prevent a relapse, so that after completion of treatment, the child does not have a relapse of the cancer later. Okay, so induction, post-induction therapy, and the third is CNS preventive therapy. So within ALL, what happens is that these cancer cells have certain sanctuary sites. Sanctuary sites are where, like the CNS, like the testes, where the blood-brain barrier or the blood-testicular barrier prevents the chemotherapy drugs from reaching the CNS. Okay, so the malignant cells, they will go and hide in the CNS, but the chemotherapy drugs are not able to cross the CNS. So what should we do? Because there are many times what happens is that the children later will have isolated CNS relapse. So over a period of time, the oncologist realized that you have to give CNS preventive therapy also to them. So in this CNS preventive therapy, what they do is an intrathecal method. The chemotherapy drugs are given within the spinal fluid, so they directly reach the CSF. Okay, and all the chemotherapy drugs will then kill all the CNS malignant cells which are hiding there. So these are the 3-pronged strategy that we use for ALL. And second is the principle of risk stratification, which I've already told you. The duration of treatment is 2 to 2.5 years. So first 6 months is induction and post-induction therapy, and the remainder 1.5 years is the maintenance therapy. Overall survival is around 60 to 80% in children with ALL, and there are different protocols used. A 10-drug therapy is often used. This you can read in the book. Now, are you guys there with me? Are you guys there with me? Hi guys, are you there with me? Not slept off, not dozed off? Hi. Yes, okay, great. I know it's a lot of information. Yes, great. Shake your legs, shake your hands. Move your head up and down, stay awake. We're going to start lymphoma. Okay, so we just finished leukemia. What you guys definitely do today is go back home and read from very comprehensively written and very well covered topics. Okay, so just stay with me, you do well. Okay, just stay with me, don't doze off. So what exactly is lymphoma? Lymphoma is again a clonal proliferation of lymphocytes. Okay, so it has only lymphocytes now. It is a proliferation of only lymphocytes. In acute leukemias, the origin could have been the lymphoid progenitor or the myeloid progenitor, but over here we are talking only of lymphocytes. So, difference between leukemia. So, leukemia arises from clonal proliferation of lymphoid or myeloid progenitor in the bone marrow. So, it is arising either from the lymphoid progenitor or myeloid progenitor, and that too from the bone marrow. But when you talk of lymphomas, they arise from clonal proliferation of only the lymphoid cells, which can happen in any part of the lymphoreticular system. So what is the lymphoreticular system? The lymph nodes, the spleen, the thymus, and the Waldear's ring. So, but this happens outside the bone marrow. So when this clonal proliferation of lymphoid cells occurs in the lymphoreticular system outside of the bone marrow, it leads to lymphomas. Now, ultimately, even lymphomas can progress to a point where they start involving the bone marrow. So that will be called stage 4 lymphoma. And over there, distinction between leukemia and lymphoma becomes bleak. But till that time has not happened, lymphomas are treated separately. Okay. So there are two main types, Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma comprises 40% of childhood lymphomas and they are B cell in origin. Non-Hodgkin's lymphoma comprise 60% of childhood lymphomas, but they can be B cell, T cell or NK cell in origin, and non-Hodgkin's lymphomas are usually much more aggressive than Hodgkin's lymphoma. They grow faster and they spread in the body faster, metastasize faster, and the treatment is more intense and the prognosis is poor. Whereas Hodgkin's lymphoma, we have almost more than 95% survival. Okay. So what is the epidemiology? Hodgkin's lymphoma usually occurs between 15 to 19 years of age. Non-Hodgkin's lymphoma slightly earlier, 5 to 15 years of age. Both are commoner in males as compared to females. And almost 70%, since non-Hodgkin's are more aggressive, they tend to appear at an advanced stage of disease. By the time they are diagnosed, they have already metastasized. So almost 70% of non-Hodgkin's lymphoma present in stage 3 or 4 at diagnosis. Okay. What can be the risk factors? There can be positive family history. There are certain autoimmune conditions like SLE and sarcoidosis. Then immunosuppression, which can be either congenital immunodeficiency or immunosuppression which has been given post-transplant. Suppose someone has had kidney transplant and they're given immunosuppression for that, then they are at increased risk of developing these cancers. And finally, don't forget infections, especially EBV. Okay, Epstein virus infection has relevance both in Hodgkin's lymphoma, highly in Hodgkin's lymphoma, but also in non-Hodgkin's lymphoma. And then you have radiation exposure. So these are the risk factors for lymphoma. Now we come to the pathological classification of lymphoma. When you talk of Hodgkin's lymphoma, there are two main varieties. The classical Hodgkin's lymphoma, which occurs in 95% of the cases. So this is obviously seen by the pathologist on the slide. So you take the lymphoma sample, that is the lymph node that is enlarged or any organ which is involved by the cancer, and they look in the slides, and what do they see in the slides? 95% of the times they see classical Hodgkin's lymphoma. 5% of the times it may be nodular lymphocyte, predominant Hodgkin's lymphoma. When you talk of classical Hodgkin's lymphoma, it is of 4 types: nodular sclerosis, mixed scalarity, lymphocyte rich or lymphocyte depleted. Okay. Then you have non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is again primarily of 4 types: Burkitt's and Burkitt's-like lymphoma, which is the most aggressive form. In endemic areas like Africa, it usually leads to a jaw mass. In non-endemic areas like in India, it usually presents as an abdominal mass. Then you have diffuse large B-cell lymphomas, which usually present a mediastinal mass. Anaplastic large cell lymphomas, which usually present with abnormal, unusual site involvement, like skin involvement may be present or bony involvement by the lymphomas may be present. And then you have lymphoblastic lymphomas. Okay, so the lymphoblastic lymphomas are treated more like acute leukemias. Now, if you look at one characteristic feature of Hodgkin's lymphoma on the slide, it would be the presence of Reed-Sternberg cell. So I tell you a very characteristic feature of Hodgkin's lymphoma. In Hodgkin's lymphoma, most of the tumor mass, suppose there is a lymph node which is involved with Hodgkin's lymphoma, most of the mass of that lymph node will actually be composed of normal lymphocytes, eosinophils and fibrosis, and the tumor cells will be very few and dispersed in between. Okay. So in fact, for the diagnosis of Hodgkin's lymphoma, you do not take an FNAC. Why don't you take an FNAC? Because When most of that mass is comprised of normal cells, then the chances of picking up the tumor cells decrease. Apheresis is just putting in a needle and taking out a very small bit of the tissue. In Hodgkin's lymphoma, you should actually do an excisional lymph node biopsy where the entire lymph node is taken out in total and sent for a pathological examination. Okay. Even true cut biopsy is not recommended. True cut biopsy mein biopsy karte ho, you take a thick core of tissue, but still it is not the whole of the lymph node. In Hodgkin's lymphoma, you take out the entire lymph node, excisional lymph node biopsy. Whereas in non-Hodgkin's lymphoma, which is very aggressive, majority of the tumor mass will be composed of tumor cells. It will be okay if you do a true cut biopsy. Okay. But in classical Hodgkin's lymphoma, you do an excisional lymph node biopsy. And over here, you look at this, most of these cells, these blue cells are normal lymphocytes and eosinophils and fibrosis. Now, this particular cell, which has a very typical owl-eye appearance, look at this nucleus. It is a bilobed nucleus. It is a large cell, almost 2 to 6 times that of an RBC. It has a bilobed nucleus, and within the nucleus, there are 2 nucleoli. So, the typical Reed-Sternberg cell, if it is present, it is pathognomonic of Hodgkin's lymphoma. Okay. Now we talk of non-Hodgkin's lymphoma. यहाँ पे क्या है? Majority of these cells जो blue दिख रहे हैं ना, यहाँ पे ये है tumor cells. ठीक है? And in between, what happens is that these are the macrophages which have engulfed some of the tumor cells, and while staining, they lose color. So this appears as white. Okay. So since it appears white, it appears like this is a dark night sky, and over there, there are white stars. So this is the classical starry sky pattern of non-Hodgkin's lymphoma. Okay. So next you have the clinical features of lymphomas. One is lymphadenopathy. What is important to note over here is that you should examine all possible lymph nodes, not just cervical, but also axillary, inguinal, popliteal, and epitrochlear and brachial. So whatever group of lymph nodes are amenable for examination, you should examine. Now look at these pictures. Here he has, this particular child has cervical lymphadenopathy. This particular child over this yellow arrow, this is supraclavicular lymphadenopathy. So if you would have not carefully examined, you might have missed this lymph node. So be careful. Then over here, there is obvious axillary lymphadenopathy, and over here, there is inguinal lymphadenopathy. And the characteristic of these lymph nodes are that they are painless, firm, and rubbery. So if you have suppuration or you have an abscess or there is pus, it will usually be a painful and it will be a fluctuant lymph node. But in this case, it will be painless, firm, and rubbery. Okay. Now, what are the clinical features? You can have an abdominal mass, especially in Burkitt's lymphoma. And because of the abdominal mass, there can be nausea, vomiting, diarrhea, constipation, and there can, of course, be hepatosplenomegaly. In head and neck, there can be a jaw mass, then there can be parotid enlargement, tonsillar enlargement, nasal obstruction because of the mass. So all these features can happen. Then other sites that can be involved, the bone marrow can be involved in stage 4. So once the bone marrow is involved, it is going to lead to anemia, recurrent infections, and bleeds because these normal cells will be replaced by the lymphoma, abnormal lymphoma cells, right? And there can be fever and weight loss. And within the skin, especially in ALCL, which is a type of NHL, you can have itching and there can be cutaneous lymphomas. Okay, so these are petechial rash. These happen if the bone marrow is involved and platelet counts goes down. So the clinical features, if you compare, in Hodgkin's lymphoma, there will be a tendency of involvement of the peripheral lymph nodes. So what are the peripheral lymph nodes? The ones you're able to examine, like the cervical lymph nodes, the axillary lymph nodes, inguinal lymph nodes. These are peripheral lymph nodes. These are not visceral lymph nodes which are present close to the organs like para-aortic or mesenteric or iliac lymph nodes. Those are the visceral lymph nodes. So Hodgkin lymphomas typically involves the peripheral lymph nodes, and within those peripheral lymph nodes, what will happen is that there will be a contiguous involvement in Hodgkin's lymphoma. तो ऐसे नहीं है कि एक cervical और एक inguinal. अगर cervical से शुरू हुआ है Hodgkin's में, they will go from this cervical, then it will start from submandibular, mental, then upper jugular-digastric, lower jugular-digastric, and then it is going to go to supraclavicular and then axillary. So it is going to have a contiguous spread. Whereas in non-Hodgkin's lymphoma, the commoner presentations are actually, if it is an endemic buckets, then jaw involvement. If non-endemic, then a abdominal mass. And even if lymph nodes are involved, visceral lymphadenopathy is commoner. And extranodal, that means outside of lymph node, other organ involvements are commoner. And even if lymph nodes are involved, it is a non-contiguous involvement. It won't be like a contiguous involvement as in Hodgkin's lymphoma. Non-Hodgkin's lymphoma is more aggressive. When you talk of Hodgkin's lymphoma, it is less aggressive, but there are 3 symptoms which, if present, portend a poor prognosis in a case of Hodgkin's lymphoma. These are the B symptoms, and these are fever, drenching night sweats, and weight loss of more than 10% over a span of 6 months. So if any one of these features is present, then you label it as B symptom positive, and it upgrades the staging of Hodgkin's lymphoma. Okay. Now, what are the investigations that you do in non-Hodgkin's lymphoma? First, focus on the ones which are highlighted in red. So, diagnostic investigation, the way you're going to diagnose is going to be a biopsy. In Hodgkin's, you're going to do an excisional lymph node biopsy. In non-Hodgkin's, you can do a true cut biopsy. Okay. Laboratory and pre-chemotherapy workup, जो नीचे दिया हुआ है. CBC, KFT, LFT, uric acid, LDH, biomarkers, and MANTO. This is done in almost all cancers before starting chemotherapy, and the premise remains the same as I explained to you in leukemia. Okay, so diagnostic is biopsy, and then you have laboratory and chemotherapy investigations. The second group of investigations, last, is how you do the staging. For staging of Hodgkin's as well as non-Hodgkin's lymphoma, you need to have a CT scan of the whole body. Why? Because you need to find out what all lymph node groups or organs are involved by the cancer, and accordingly the staging will be done, and depending on the stage you decide the duration of chemotherapy. Okay, so you do a CECT of the neck, chest, abdo in both cases. Now again, you also need to know whether bone marrow and the CNS is involved. In non-Hodgkin's lymphoma, you do a bone marrow aspirate and biopsy in all cases to find out if the lymphoma has spread to the bone marrow or not. You do a CSF in all cases to find out if the NHL has spread to the CNS or not. In Hodgkin's lymphoma, however, you do a bone marrow aspirate and biopsy only if with the CT scan, the staging is more than 2B, or CSF if the CNS symptoms are positive. CNS symptoms means if there are seizures or there are cranial nerve palsies or there is altered sensorium. In those situations, you will do a CSF in a case of Hodgkin's lymphoma and not in all cases. Okay, so understood. Diagnosis is where biopsy, you have lab and other parameters, and then you have staging in which CT is done, neck, chest, abdomen, all cases. Bone marrow aspirate and biopsy and CSF in all cases of NHL, and in certain cases in Hodgkin's lymphoma. Now these are the staging categories. This is the Ann Arbor staging for Hodgkin's lymphoma. Stage 1 is one group of lymph nodes involved on one side of the diaphragm. So this is the diaphragm. This is the line which crosses the diaphragm. I have hypothetically generated this line. So if there is one lymph node group which is involved on single side of the diaphragm, it is stage 1. If there are 2 or more than 2 groups of lymph nodes which are involved, but on the same side of diaphragm, it is stage 2. If 2 or more group of lymph nodes opposite side of the diaphragm, stage 3. And if it is metastatic, where it involves the bone marrow or the liver or the spleen, then it becomes stage 4. Okay. This is the St. Jude staging for NHL. Just the same as Ann Arbor. There are certain additional parameters which have been given. That is, if there is a primary GIT tumor which is grossly resectable, that is when you do the surgery, more than 90% is taken out and there is no involvement elsewhere in the body, yet it will classify as stage 2 only. Okay, so primary GIT tumor which is grossly resectable is stage 2. If there is a primary GIT tumor which is not grossly resectable, stage 3. Or if there is primary intrathoracic, paraspinal or epidural tumor, it is again stage 3. Rest of it, the staging was same as Ann Arbor staging. Okay, so this is St. Jude staging for NHL and Ann Arbor was for NHL. Now, what will be the treatment? So based on the staging, The duration of therapy is decided. Mainstay of treatment for both Hodgkin's and non-Hodgkin's is chemotherapy. For Hodgkin's lymphoma, the treatment is 4 to 6 months. 4 months if it is stage 1 or 2. 6 months if it is stage 3 or 4. Okay. NHL treatment duration is 6 to 24 months depending on what pathological subtype is present and what is the staging. One example of the most commonly used regimen in Hodgkin's lymphoma is ABVD, which is adriamycin, bleomycin, vinblastine, and dacarbazine. BFM is one of the treatment protocols which is used for NHL. Now, what is the indication for radiotherapy? There is very few indications for radiotherapy in NHL and HL. If the tumor at the time of diagnosis was bulky means more than 10 centimeters in the long diameter, which is told to you by the radiologist when he does the CT scan. If it is a bulky tumor, then you give radiotherapy. In cases of NHL, if it is lymphoblastic lymphoma subtype with CNS involvement, in that situation you give a cranial radiotherapy. Prognosis in Hodgkin's lymphoma is good with more than 95% survival, and in cases of NHL, overall survival is 70 to 90%. In India scenario, around 60 to 70%, depending on the type and stage of disease. Okay. So the mainstay of therapy in both Hodgkin's and non-Hodgkin's lymphoma, as well as in acute leukemias, is chemotherapy. Okay. So that brings us to the end of the second tumor, that is lymphomas. Now we have Wilms tumor left. Are you people there? Yes, you guys are there. Not bored with me? With me? Awake? Shake your legs. Last 5 minutes. Yes, last 5 minutes. Okay. Okay, beta. Okay. Last 5-7 minutes. Okay. I'll get you through this quickly. Okay. So this is Wilms tumor. Nephroblastoma, which is the commonest malignancy of the kidney in children. Okay. So the peak incidence is 2 to 3 years of age, just like ALL. The peak incidence of Wilms tumor is also 2 to 3 years of age. Now, ALL may less than 5% of the children you are able to detect any risk factor. But in Wilms tumor, in almost 10% of the cases of Wilms tumor, you are able to identify an underlying genetic abnormality. What are the 3 commonest genetic abnormalities that you see in these cases? One is WT1 loss. Wilms tumor 1 gene is a tumor suppressor gene. So if a tumor suppressor gene is knocked off, of course, there's going to be increased risk of cancers. So the WT1 loss, and then there are 2 more pathways. This is the WNT pathway activation and IGFT overexpression. Okay. The risk factors, genetic syndromes are present in almost 10% of the cases of Wilms tumor. So amongst them, 3 common ones are Dennis-Drash syndrome, Berger syndrome, which is an acronym for Wilms tumor, aniridia, genitourinary abnormalities, and mental retardation, and Beckwith-Wiedemann syndrome. And 1 to 2% of the cases of Wilms tumor are familial. So you'll get a family history of Wilms tumor also present. So what is the Dennis-Drash syndrome? So this is a risk factor for Wilms tumor. 3 components of it is, one is a Wilms tumor. If you look at this, this is a CT scan, a cross-sectional film. This is the right side, this is the left side. This is the kidney that you see. This is a normal kidney. On this side, you see that the kidney's architecture is distorted. This is a Wilms tumor. Then you have male pseudohermaphroditism. What does that mean? Actually, the karyotype is XY, but phenotypically, the child is a male. So a mother may get, and the third component of Dennis-Drash syndrome is diffuse mesangial sclerosis, which is present in the kidneys. And this usually presents as your steroid resistant nephrotic syndrome. Okay, so a mother may get a child, a girl who is around 12 years of age, and you are treating her since 3 years of age, and she is a steroid resistant nephrotic syndrome, and now she has developed Wilms tumor. So, and when you know that it is a steroid nephrotic syndrome, steroid resistant nephrotic syndrome, you did a biopsy, you found diffuse mesangial sclerosis. Go ahead, do the karyotype of this child. This actually female might be karyotypically a male. He may actually be a male pseudo hermaphrodite who has developed Wilms tumor and DMS. Then you have the Vagar syndrome, in which you have Wilms tumor, so the acronym Wilms tumor, aniridia, that is absence of the iris, genitourinary abnormalities like duplicate uterus or horseshoe kidney or hypospadias may be present, and then there is intellectual disability. The acronym says R, so it is mental retardation. Okay. Then you have the third syndrome, which is the Beckwith-Wiedemann syndrome. It is a hemihypertrophy syndrome. So these are the two scientists, respected scientists, who gave this syndrome a name, who recognized this syndrome. The first component of it is hemihypertrophy. This is again a CT scan film, the right and the left. And if you look at the left side, the kidney is so large as compared to the right one. And the whole of the left hemi side is hypertrophy. So this is hemihypertrophy. They have macroglossia, where the tongue protrudes out of the mouth. Then they have an earlobe crease. So you usually do not have a lobe crease, but these children have crease. Then you have microcephaly and umbilical hernia. These are some of the features which are present in Beckwith-Wiedemann syndrome, and these children have a tendency to develop Wilms tumor. Now, what is the pathology? If you send the slides to a pathologist, you can find a combination of blastemal, epithelial, and stromal cells. What is important is that these blastemal cells appear like a typical small round blue cells. So, can anyone tell me about the other small round blue cells tumors? Anyone? Small blue round cell tumors? SRBCTs? Anyone? Examples? Hi, you guys there? Yes, examples. Good. Neuroblastoma, excellent, Alicia. Yes, Ewings. Yes. Okay, so neuroblastoma, definitely you guys should know. Yes, certain Ewing sarcoma. Good, good guys, good, good. So Ewings and neuroblastomas, some categories of NHL also present as small round blue cell tumors. Rhabdomyosarcoma is something you should also remember. Okay, so they can present as small round blue cell tumors. Okay. So if there is a significant component of these blastemal cells, these small round blue cell tumors cells will become prominent, and when they're present, they're more aggressive tumors, but they're also more chemosensitive. Okay. Then what could be the clinical features? There could be an asymptomatic abdominal mass. So the mother may be bathing the child, and suddenly during bathing, she identifies that there's something protruding from the abdomen. So she may bring to you and tell, "Okay, there's a mass which I just noticed while bathing my child." So this is the most common presentation. Then these kids can also have abdominal pain in 30%. Some may present with blood in urine, that is gross hematuria, in 10 to 25%, fever in 20%, anorexia, vomiting, and on examination you may find hypertension in almost 1/4 of these children. Okay. The complications that can happen is anemia. You can have thrombocytosis, acquired von Willebrand factor and factor 7 deficiency, and polycythemia. The commonest site of distant metastasis is the lung. So for most of the solid tumors, if you do not remember the site of metastasis, it is the lung. Okay. Except for neuroblastoma, where the site of metastasis, commonest site of metastasis is the bone. Okay. Other sites of distant metastasis can be, just give me 1 minute. Hello, sir. मेरी ना actually UG class चल रही है. Yes, yes. I'll just call you back. Okay. Okay. So the other sites of distant metastasis can be the liver. Then again, there can be renal or IVC thrombosis due to the contiguous spread of the tumor. So it arises from the kidney, and then it spreads into the renal vein, and then it can go contiguously reach up to the IVC. So if this feature is present, because what happens is when you do the radiology of Wilms tumor, usually if there is a confusion, it is with neuroblastoma. Okay. But if you find a tumor which has contiguously spread from the kidney to the renal vein and then to the IVC, it is more or less confirmatory of a Wilms tumor only. Okay. Now, what are the investigations? Of course, you do an abdominal ultrasound to localize the organ of origin. If it is the kidney, it's likely to be Wilms tumor. If it is the adrenal gland, it is going to be neuroblastoma, but sometimes the distinction is not so obvious. Then you do a CT scan. So a CT scan has to be done in all cases of Wilms tumor, because not only it helps you to localize the tumor, characterize it better, but also helps you to find out the sites of spread of this tumor. Then you do an FNAC for the cytological confirmation of tumor type prior to chemotherapy. Now this is the staging which you should go back and read from your books. Very briefly, if I tell you, stage 1 is tumor confined to the kidney. Stage 4 is with distant metastasis, and stage 5 is with bilateral renal involvement. Stage 2 and 3 is in between. So you go back and you read and you'll understand this better. Okay, 1, 4 and 5 is easy to remember. 1 is confined to the kidney and completely excisable. 4 is metastasized to lung, liver, or rarely bone and brain. And stage 5 is bilateral renal involvement. Stage 2 and 3, there are certain criteria which you should go back and read and learn. Okay. Now, treatment is primarily surgical and chemotherapy. There is very limited role for radiotherapy. Okay. There are two schools of thought for treatment of Wilms tumor. The COG group says that you upfront resect the tumor. So if you detected a Wilms tumor on the CT scan, you just take out a resection of that tumor, and it will lead to a more accurate diagnosis, because once you've taken out the tumor, you're going to send it for the histopathological examination, and after that you can give chemotherapy. Now the problem with this particular way of treatment is that once you do a surgical resection, there is a risk of tumor spill while you're doing the surgery. So the other school of thought says that you give a preoperative based on the CT scan or maybe an FNAC, but without a biopsy. You give a preoperative chemotherapy and you shrink the tumor a bit, and after that you take out the tumor once it has shrunk. So it decreases the risk of tumor spillage, but it leaves that teeny weeny bit of doubt that whether this was surely a Wilms tumor, because you have not done a baseline histopathological examination for this child. But these are in equal amounts followed all over the world. Both these strategies are equally followed all over the world, and they have near about the same results. There is very limited role of radiotherapy. Now, based on what stage of tumor you have, you decide what chemotherapy or surgery or radiotherapy is given. So if a children less than 2 years with tumor size less than 550 grams and with a favorable histology, only surgery is done, that is nephrectomy is done. The kidney is taken out. For stage 1 and 2, surgery and chemotherapy is done. For stage 3, surgery and chemotherapy is given, but the duration of chemotherapy is longer. For stage 4, surgery, chemotherapy is done, and along with that, radiotherapy is given for pulmonary metastasis. And prognosis is usually good for these children with Wilms tumor. Almost more than 90% survival has been reported in the Western literature. So that brings me to the end of this lecture. It was a marathon round. All I would like to say is you guys should go back and read your Ghai today. Otherwise, you tend to forget a lot of things. Okay, lots of things you've read today. You do not find fluctuant lymphadenopathy in lymphoma. The heck, you do not find fluctuant lymphadenopathy in lymphoma. It is firm and rubbery only. Fluctuant is if you have a lymphadenopathy and you have pus in that. That will be a different, it will be a differential diagnosis. That is suppurative lymphadenitis. Okay, that is different. Okay, so that's about it. Okay, guys, thank you. Thank you. Thank you for being with me. Okay.